Moving on, I'm so excited to have an esteemed guest as our next presenter, Professor Dean Fennell, former recipient of our Foundation's Pioneer Award, will be presenting on what's new in clinical trials. Dean Fennell is a professor and consultant, as well as director of the Mesothelioma Research Program at the University of Leicester in England. He's an international leader in mesothelioma research. Welcome, Professor Fennell.
Well, good morning, everybody, and it's a real pleasure to speak to you today. Okay, then, so I'm going to give you hopefully some insights into new treatments that are emerging, and hopefully some advice around how we may be able to make existing treatments better using some lifestyle changes. So I'm going to sort of divide my short talk into these three sections. I'll start with immunotherapy, then talk a little bit about what's new around chemotherapy, and then focus the majority of my talk on targeted therapy. These are personalized treatments, treatments that are unique to the individual, and hopefully, actually, the future of how we're going to most effectively treat this terrible disease. So let me start with immunotherapy. I'll actually, first of all, though, start with an observation. Over the last sort of 2 decades or so, since I've been treating patients with mesothelioma, there are 2 factors that really have sort of struck me as being critical to how well we can do in terms of keeping patients well and alive. The first is maintaining fitness, and I will talk a little bit more about that. Performance status. If you're fit, you can receive treatment. It's as simple as that. Normally, having a chemotherapy or some form of drug requires that the patients have a sufficient level of fitness, and there are things we can do to try and maintain that. And then the second, and this is really the topic of this discussion, is effective treatments and the availability of those. So thinking about the second point initially, we have very limited licensed treatments for the treatment of mesothelioma, and this is a problem in itself. Because as you can see here, there are only really 2 stages where a patient can get treatment. The first of these, some of you in the audience may have already received actually, is immunotherapy with ipilimumab and nivolumab. This is a relatively new treatment that was licensed around 2021-22. And I'll show you how effective that is. If you receive this treatment, you then have chemotherapy as your next option. And then that's it in terms of licensed treatments. A new treatment, which was introduced only very recently, licensed by the FDA, involves the combination of immunotherapy and chemotherapy. And this sort of combination has some effectiveness, but it's not a million miles away from what either of these older treatments can do. And actually, the situation in terms of the number of therapies that are made available to a patient to keep the cancer under control over time, well, that situation becomes worse when we think about chemoimmunotherapy. Why? Because both of these options are taken in this one therapy, and once the patient has progressed, you're really then thinking about clinical trials, actually. So there are some treatments which are off-label, and this is sort of good news for those who can access it. And we can see here a number of treatments in the second and quite a few now emerging. And this is increasing in the third line. Now, these are treatments which are not licensed by FDA, but where there's evidence, and actually, correct myself, they are licensed, but perhaps in other disease contexts, lung cancer and so forth, breast cancer. But evidence has suggested that these may have activity, and therefore, where these are accessible, these may be able to extend the runway, as it were, for patients and the control of their cancer. So just a very small bit about what the licensed treatments actually do, because this is important. If we think about immunotherapy, now on average, we can see that the survival, the overall survival of patients, this is what we call a survival curve. All of us have one of these. And if we look at the normal population, this is the population of individuals out on the street. Of course, over time, we all have finite life expectancy. But when we compare life expectancy following the start of treatment with ipilimumab and nivolumab compared to chemotherapy, in the pivotal trial Checkmate 743, what we can see is a red line sitting on top of the blue line. This implies improved overall survival. And the measure of this, you can see 18 months for the immunotherapy versus chemotherapy at 14 months. Now, this is an average. There are some patients with more aggressive tumors that are resistant that will do worse, and there are some that will do considerably better. I've had one patient, for example, who had treatment on this schedule from the trial back in 2017, had a very aggressive tumor, developed toxicity, but actually today has not had any further treatments. So that's 2017 to 2025. And that's a rare event, but it does imply that there are some extreme benefiting patients out at the far end of this curve. And you can see it almost plateaus off, actually. It doesn't go to zero, suggesting that patients over long periods of time may benefit from immunotherapy, but we need to understand why. If you think about chemoimmunotherapy, the benefit, well, you may agree actually, the red line isn't sort of perhaps as nicely spaced compared to the blue line here, but nevertheless this trial met its objective. You can see the overall survival here was actually significant for this, and this was FDA approved and can be used in some countries, including the US. The advantage of this treatment, if there is one, is that the rate of shrinkage of the cancer is higher than we see for immunotherapy alone. It's about 62%. And that's important because if you're symptomatic, for example, with pain, having chemoimmunotherapy may, by shrinking the tumor down, actually, and this is entirely theoretical, by the way, I don't have clear evidence to support this, but we do know if tumors shrink more, they may actually help with symptoms such as pain. Now, immunotherapy can be retreated. Patients who have had a limited period of time, that is to say 2 years, 24 cycles or so, 24 months rather, will benefit from having retreatment. If there was benefit before, there is evidence here from a study that's published in The Lancet Respiratory Medicine that actually retreating can be associated with improved survival. Here, the blue curve is the good curve, if you like, so the colours have been reversed here. Now, what's new? What new trials do we have in the immunotherapy space in the front line? This is the first treatment that patients might receive after diagnosis. Well, ipilimumab and nivolumab are two drugs, and those drugs can now be combined into a single drug called a bispecific. And why is that important? Well, by having two drugs in one, they don't just go off anywhere and bind to different organs as efficiently, so if you have this molecule as efficiently as other two molecules might do. What do I mean by that? Well, cancer cells will have the targets of this drug expressed, and because it's one molecule, it'll go to where it needs to go, sticking to those two proteins. So this treatment, we believe, may be at least as effective, possibly more effective, possibly less toxic, than using two drugs. And there is a clinical trial now that's ongoing. It's ongoing in the USA. Our own Marjorie Zasaldra, who's based in New York, actually is one of the co-global leads for this study. And this is a trial, put simply, of combining chemotherapy with volrustomig, so 3 drugs, but essentially doing the equivalent of adding ipilimumab and nivolumab to chemotherapy. So this is a big study, big international trial, and we should be seeing the results of this perhaps in the next year or two, once we've had all the mature data. So an obvious question is, as I refer back to my 2017 patient, why do some patients have extraordinary responses? You can see here in this CT scan the disease that's occupying most of this patient's right side of the chest. Why is that almost gone after 2 cycles? Well, we try to address this question actually in multiple clinical trials now that we've run using sort of molecular information. So what's very clear though, and I just want to point you to this graph here. Now you can see the space between these lines is very different, very large difference. And these patients in blue here are the responders, and these are the patients who do not respond. So this is what you call a waterfall. This is growth here, and this is shrinkage here. So there's no doubt about it. If you have a response to immunotherapy, you're going to live longer with this disease. So how can we improve the chances of responding? Well, this is what I'm going to tell you is conjectural, actually, but the evidence is mounting that there may be factors that we can control that could improve the likelihood of benefit. And so what I'm thinking about here really is an experiment that was published in the journal Science a few years ago by Spencer and colleagues, where they looked actually at the gut microbiome, the bacteria in the gut. And all of us have these bacteria, and these bacteria over the last few years have been shown to have profound effects on the immune system and also our ability to affect immunotherapy. In other words, if you've got good bacteria, you respond to immunotherapy, and if you don't, you do not respond. And one way in this fantastic study that they were able to modify the gut bacteria, well, we all know the answer to that, actually. It's eating fruit and vegetables, is what our parents told us. So, you know, plus ça change, as they say, but really what we have is a way in which by increasing the fiber, and I think it was about 30 grams actually a day, it was possible to measure the change in the gut microbiome and actually take patients who hadn't responded to immunotherapy and make them respond. This wasn't mesothelioma, but the principle, I think, is important. Well, how important are the gut microbacteria in patients with mesothelioma? Well, I think very important, actually. And in fact, this is a graph that I'll just take time to explain. These patients in this group called R responded. They had shrinkage of their tumor, and these NR did not. And what we're measuring here, it's a complex variable, but basically what it is just a measure of how good the bacteria are in the gut. So we're able to do that. We're able to sequence, DNA sequence on the gut bacteria, and then we can work out what's present and what's absent, and then we can say what's good and what's bad. And no doubt about it, here we are. This is a very small trial, so this is a very powerful effect that we're seeing. There's more tumor shrinkage here. That is to say, as you increase this index, this good bacterial index, you see shrinkage reduction in the tumor size, and actually the duration of how long the therapy is working increases as you increase the number of good bacteria. So better bugs in responders, that's what that's showing there. And actually, we've now validated this in 3 clinical trials. We've yet to publish these papers, but you know what I would say, and I do say to my patients now, is if you're diagnosed with a mesothelioma, eat your fiber, get your fiber in, because there's a possibility. We need to validate this in a study, and we're going to do that. But you know what we need to do now is to, in a relatively harmless maneuver, try to improve the odds for patients, and diet may be one way in which we can do this. I should also say a second paper came out around vitamin D, showing a modulation favorably of the gut microbiome, and that's, again, very simple maneuver that may have some benefit for patients. Certainly harm, I think, is extremely low risk for this. Very briefly talk about chemotherapy and new advances, or some of them not so new, but important. Avastin, a drug that is licensed in lung cancer and other cancers. This blocks the formation of blood vessels. Small benefit here actually for patients in red, but nevertheless significant. This was not licensed, but may, if one is having chemotherapy and there is access to newer drugs, Avastin, certainly on a phase 3 trial published in Lancet, would be highly recommended. In the also first-line setting, this is a recent trial that was published. We're seeking FDA approval for this, but this is the combination of a new drug that starves the tumor of a particular amino acid that's found in protein, called arginine. And this study, again, met its primary endpoint: better survival, better disease control. This blue line, sorry about the color swaps, actually, but the blue line this time sitting on top of the red, implying better outcomes for patients. So this is a simple, low toxicity injection that patients get weekly, and it does appear to confer benefit to some patients. And finally, the drug gemcitabine, a drug which has been around for a very long time indeed, but 2 trials show benefit. One is if we use gemcitabine plus this ramucirumab drug, a new drug. This was an Italian study, and I think it's marked out by the fact that there was really quite a sizable improvement in overall survival. And one has to ask the question, why? Why are these so-called anti-blood vessel or anti-angiogenic drugs improving overall survival in that trial I just showed you called MAPS, and also in this trial called RAMES? Well, we don't absolutely know, but there are some suggestions coming from our basic research. We're able to look in patients with biphasic mesothelioma. These are the tumours that have both epithelioid, the more common, less aggressive tumour, and little bits of sarcomatoid present in the tumour. And if we begin to look geographically at the changes that occur, we can see that one is converting into the other, that the epithelioid is converting into sarcomatoid. We can see that within the tumour at the molecular level. And what's interesting is that as that conversion happens, new blood vessels are being formed, or at least there is a drive to make new blood vessels. And that's what's inhibited by these drugs. So one suggestion is that this conversion to more aggressive mesothelioma that could happen over time may be blocked by inhibiting vasculature, and that may be a factor contributing to overall survival improvements with these classes of drugs. Anyway, in our experience, this has been quite an effective therapeutic approach. It's not licensed, but the evidence is there and therefore may be accessible to some patients. And then finally, for those who can't get the ramucirumab, just giving gemcitabine, just that chemotherapy after standard pemetrexed platinum chemotherapy as what we call a maintenance. This is a study from our Dutch colleagues. I mean, look at the gap between the blue and the black lines here, very substantial gap. And so we can improve the outcomes with simply chemotherapy, standard chemotherapy, by making the small addition and adding gemcitabine. This is a trial I published a few years ago. Vinorelbine, it's a tablet or capsule, can be given weekly. It's a generally well-tolerated drug, and again, good distance here between the curves, suggesting that there is some activity, at least in disease control. Although not FDA approved, this is actually in the NCCN, the US guidelines. Can we give chemotherapy again? And the answer is emphatically yes. Patients who have benefited with more than 6 months of control of their cancer do appear to benefit again if they're treated. And you can see here, this illustration is probably the simplest thing to look at. Again, look at the space between these lines. That does look relatively substantial. So that's really suggesting to us that we can reuse, we can recycle therapies dependent on how patients tolerated them and if they benefited previously. Right, I'm going to move to the last part of my talk very quickly, and this is targeted therapy. One of the challenges that we faced, and only now can address, is how do we really take account of the fact that not all mesotheliomas are the same. This individual here has a different mesothelioma from every other mesothelioma in the room. And should we really expect that that patient should be treated identically to everybody else? Well, the answer, of course, is no. But what I've shown you entirely in my previous slides has been a one-size-fits-all approach. And this clearly can't work if we're thinking about getting very high response rates. So I'm going to tell you about some exciting new data that's emerging, and actually what I'm going to say isn't the full story. There are other really exciting changes on the horizon. This is something called a PRMT5 inhibitor. About 7 years ago, actually, discovery was made. Put very simply, there is a mutation that's actually quite common, makes cancers more aggressive, called MTAP. If you have MTAP, you have sensitivity to this form of inhibitor. Cut to the current day, and we have a tablet called a PRMT5 inhibitor, and this can shrink mesotheliomas. This is from a phase 1 clinical trial. You can see in mice, actually, if you've got the mutation, that these tumors are actually shrinking, they're regressing, they're not being stabilized. So targeting this PRMT5 using this next generation of inhibitor is an extremely promising approach, and is one that we now see in clinical trial. We have a trial in the UK we'll be opening. I believe there will be trials, new trials for patients with mesothelioma. What's required, however, is to have the presence of this MTAP, the deletion, in order to be able to receive the drug. It simply doesn't work if you don't have it, but that's a good thing because you don't want to receive a drug that's going to be useless. This is a really new, very important a target called TEAD. I bring to you now some news from last week. I was in Berlin at the ESMO. This is the world's biggest cancer conference, apart from ASCO, which is in Chicago every June. Suffice to say again here, if you look at these two curves in B, what you're seeing is a drug that kills. You're reducing viability very effectively. But you're not if you don't have the mutation called NF2. And so a phase 1 trial, a phase 1 and 2 trial, led in part by Hedy Kindler, who many of you I'm sure will know very well in Chicago, and Tim Yap, former Englishman who's now working in Texas, really was quite outstanding actually data shown, and this has now got fast track designation. In summary, these tumors are stabilized and indeed shrunken down by a tablet with very low toxicity called a TEAD inhibitor. And we can see ongoing benefit for patients actually who have these responses. Now, in terms of the actual numbers, 32% of patients were having responses. This is as good as immunotherapy or chemotherapy. The disease control was extraordinary, actually. Normally, if you look at ipilimumab and nivolumab, we would say the disease control rate's about 58% or so. This was 85%. And patients, there may be ways, you can see a response here happening in the chest of a patient on CT scan. There may be ways in which we can select patients even better. But the biomarker is extremely common. It's called Merlin, the protein. And because of this, there's a proposed phase 3 that's going ahead. I just want to draw your attention, this is quite a complex table, but suffice to say that severe toxicities, very low indeed. More news from last week. I presented data on a trial called NERO. This was using a PARP inhibitor. Again, another oral therapy that has been used for quite some time in breast and ovarian cancers. We ran a trial. This was a randomized study, active symptom control versus the drug, and then we ran a lot of sequencing. The overall result was favorable. You can see a gap here between the lines. And actually, the number of patients who had disease control, not bad actually, 76%, with some shrinkage and actually major shrinkage of the tumor. The most important finding which we've made now is from DNA sequencing, we can predict who's going to benefit. And we can do that actually very accurately using a genetic marker. We need to know how to build this into clinical practice routinely, and we've got some clues to do this efficiently. But if you've got the biomarker, big gap, huge gap actually. If you don't have the biomarker, well, you're better off having nothing, almost. You know, the difference between these lines suggests actually that having nothing is even better than this drug. So the biomarker is absolutely critical. Okay, there are many other drugs coming with all these sorts of new targets, and what we really want to do, as I say, is in personalized therapy, give drug A for patients with disease A. And the way we're going to do that, at least in the UK, will be to select patients and then give them appropriate treatment. And we have a program called the SELECT program. We are keen to go international with this as soon as we can, and we're currently working with Netherlands and Australia as part of the team that are going to deliver this. So in summary, off-label treatments can expand the evidence-based treatments available to patients who are fit to receive it beyond. We have something called NICE in the UK, which is a government body that regulates the payment of drugs. New promising treatments can extend opportunities for disease control. And as I said right at the beginning, the more treatments a patient has, the more likely we'll be able to keep those patients well. And this is something that I see time and time again in my practice, those patients who don't necessarily have the best of the best mesotheliomas. They do progress, you know, over periods of time that we expect. But if the treatment is there and the patient is fit, you can continue to keep patients well. And finally, clinical trials are an incredibly important route of access to the newest therapies. And thankfully, with science, we're seeing a lot of new treatments emerging. I think we're at a real turning point in how we're going to treat this disease over the next 5 years. I'd like to thank my colleagues and thank you very much for your attention. Thank you.
Thank you. This is really fascinating. I just have to ask if all of the results you discussed apply only to pleural, or can we infer that they apply to peritoneal as well?
Yeah, I can absolutely confirm that this applies to peritoneal. Thankfully, with TEED, which I don't know how much I can say about this, but I think based on the evidence that everybody saw at ESMO, a lot of the responses were seen in patients with peritoneal mesothelioma. And I don't doubt, actually, that the phase 3 trial will include patients with peritoneal mesothelioma, which is unusual for a global, commercial study. All of our trials include patients with peritoneal mesothelioma, including the PARP. Thank you.
Have you seen any demographic data that reveals anything? Because I'm noticing that, like with my husband, his genetics are two different kind of demographics. Mm-hmm. And it seems like the demographic that is on one side is more prone to cancer, whereas the demographic on his father's side is miraculously lived through cancer. Mm-hmm. So I'm wondering how much that's seen in the medical community. You're actually looking at, for some reason, this group is not succumbing to mesothelioma as much as this group or this group, and if that's being investigated at all.
Mm-hmm. So the most extreme example of that susceptibility is, of course, a gene called BAP1. About 8% of patients with mesothelioma have this gene. And it's a predisposition gene. If you take this gene and you modify it as you would modify it in a carrier, somebody who's inherited it, in a mouse, that mouse will develop accelerated mesothelioma on exposure to asbestos. Now, we know that that's not the only gene, actually. There is another gene that was discovered recently by the same team that revealed this predisposition with BAP1. And the main challenge, I think, in trying to identify more genes is simply the rarity of mesothelioma. There is actually some good evidence from something called GWAS studies, these are gene-associated studies, using global populations, big populations, that suggest that there may be other genes that can predispose. What's interesting about the BAP1, and I think this is very important, last thing to say, is that although it's a predisposition, patients who have it have a much, much longer survival expectancy, 8 years on average, actually, if BAP1 is present. So there are other things to think about, tumours that may occur outside of the pleura, such as meningiomas, which are benign, but also renal tumours as well. So monitoring is extremely important. But to answer the question about geography, that I can't say. I don't know if there are pockets of patients with particular predispositions. Thank you. Thank you.
Doctor, I have a question about the first part of your presentation, the immunotherapy with the 2 drugs that were up there. My husband got that, and he was 3 months into getting it with no positive success. Wasn't helping at all. My son and I were reading every PubMed, everything we could, and I found protocol for these drugs strongly suggested that you needed fiber.
Mm-hmm. Oh, that's interesting. That's interesting.
And nobody told us that. And it was like, why didn't they tell us that?
Yeah. Well, thank you for sharing that. I think in terms of immunotherapy, absolutely, certainly, and I think my graph showed that not everybody responds. Now, part of this may be to do with the gut microbiome and could be modifiable, but there may be some tumours which require something else in terms of being able to achieve responses. But, we hope that studies like a prospective dietary study could provide people with evidence to, yes, maybe make that change. And yes. Thank you.
I had a question regarding what you were saying about the BAP1 with an average survival of 8 years. Are you talking about germline or tumor? Because I do not have the germline, but I do have it.
Right. Thank you very much indeed. Yes. So survival is better for not having germline compared to having it. MTAP, surprisingly, or that marker for the PARP, confers a much worse outcome. So we know now some of these genes are good to have and some of them are bad, but there are treatments for both. I think that the germline is what I was referring to, actually, the 8% that have this much longer survival, and it's not clear to me why. Why should a mutation do this? That's correct, yes. Some of the work, I may just very briefly, will present actually later in this IMIG conference actually, is around the science of what's happening in the genome. It looks like the germline BAP1 tumors are extremely stable genetically. They don't acquire mutations in the same pace as the more aggressive tumors. And that may be the big sort of distinguishing feature, particularly if you have BAP1, that it's not as mutagenic, it doesn't change as fast. Thank you.
Thanks so much for your presentation. Given the link with microbiome, are there any clinical recommendations for how one should use antibiotics?
That's a really good question. So one of the challenges, and again, patients here may sort of have had this experience. Certainly in the UK, we see this. Some patients may present with kind of vague symptoms of breathlessness, and maybe they may even get a chest X-ray, and it shows a bit of whiteout. And the first thing the community doctor says is, "Oh, you've got a chest infection, take these." And they're feeding. Now, this is a big problem, I think, for patients with chest cancers, where essentially not only are you delaying the diagnosis because you think you can do something that can improve this problem, but also you're possibly destroying the very thing that patient needs to deal with it. So are there guidelines? There should be, I think. I mean, certainly where it comes to the microbiome and how we can change it, that depends on these new studies. But if I were asked, and if we were writing the next guidelines, Kevin and others, my suggestion would be, to include a statement about this. We see clear evidence from studies that have been done in other cancers that antibiotics are a negative predictor of outcome.
Can you speak to different kinds of antibiotics, broad spectrum versus targeted, long course versus short?
I would say, in general terms, broad spectrum would be worse. Now, this has to be sort of caveated with a very important statement. I mean, patients do get infections, and infections, particularly in patients who may be a bit immunosuppressed with cancer, can die from these. So, I would say that in a setting where patients are pre-diagnosis, who've developed, an infection, it's a difficult decision for any GP to make. Yes, there is that risk of an antibiotic, but I think the same thing happens as if you're coughing up yellow sputum. It's a clear-cut infection. Get antibiotics, because you want to be alive to get your treatment. That's got to be pragmatic. Thank you. Thank you.
Morning, and thank you.
Thank you.
Earlier in your presentation, it's a follow-up to another conversation. You talked about good gut bacteria.
Yes.
And, I think this was part of a conversation yesterday, nutrition, and also this morning in your presentation. Mm-hmm. So this is new to me too. And can we actually test for that ahead of time? I mean, what can we do ourselves to advocate, understand good gut bacteria?
Thank you. Absolutely, you can test beforehand. There's a program actually in the UK called Zoe, actually, which they may have closed this off now, but you can see it on the internet, actually, on YouTube, Zoe. And the Zoe program involved testing people's gut microbiota, actually, not just for cancer-specific therapy or in a cancer setting. And I do believe, actually, that there are companies out there that have ISO kind of approved tests, for CE-marked tests. And it'll tell you whether you've got a good or bad bacterial load in the gut. What I can probably say, though, even without spending the money, is if you're eating enough fiber, you probably do have a good gut microbiome. But the thing is that these bugs, the good ones only eat what comes down all the way. And if you're eating the fiber, you're feeding them. And you can change the gut microbiome in hours, apparently. You can do the sequencing after a meal and begin to see these changes in the balance. So I think just going ahead now and just making sure you eat a good, healthy, balanced diet with fiber is the way.